system is really quite variable. And if I substitute a drawing that they made from a pathological specimen, in this case there are 3 fascicles that make up the left bundle branch, a very large posterior hemifascicle, an anterior hemifascicle which was quite a bit smaller, and there was also a branch that fed the septum. But the one thing that was found in this study of a large number of autopsy specimens is that the actual shape of the conduction system is extremely variable. And these were some examples of what they found. So this is the one that I have superimposed on my heart, but you can see that there's almost infinite variations on a theme. But electrocardiographers have described hemifascicular blocks using rather specific criteria, and we'll go over that, but keep in mind that anatomically, it's not always as clear as we make it out to be. Well, to understand hemiblocks, you have to get an idea of the 3-dimensional anatomy of the heart, and that's kind of challenging for beginners, but I'll try to help you through it. If you take this diagram of the heart lying in the chest and imagine someone uses a knife to slice it open in cross-section, and we can do this with 2D echocardiography, we can actually see the heart in cross-section with the left ventricle, which is a more rounder chamber, and the right ventricle, which has a little bit more of a curvy shape. Now I want you to notice that there are 2 papillary muscles that are indeed connected to the heart. So these papillary muscles are what maintain the mitral valve from prolapsing. So here's the mitral valve. The edges of the valve leaflets are connected by strings called the chorda tendineae, and the edges of the leaflets are connected to 2 heavy-duty muscles that come off of the inside of the left ventricle. And these papillary muscles are designed to make sure that the valve does not just blow open into the left atrium. So when the left ventricle contracts and the valve leaflets close, these papillary muscles are designed to contract, and as the heart chamber size shrinks with the contraction of the heart, it maintains the proper tension on these chorda, and that maintains the proper spatial relationship between the 2 mitral leaflets. So the chorda are involved in maintaining competence of your mitral valve and keeps your mitral valve from prolapsing and leaking backwards. And when we slice the left ventricle in cross-section, we can see these 2 papillary muscles. Well, the conduction system runs in close approximation to these papillary muscles. Now, as I mentioned, physiologically we believe there are 3 branches, although most people don't talk about the septal branch. But imagine that there's a septal branch that runs down the middle of the septum. Then there's an anterior branch that runs across the aortic outflow tract and winds up running near the anterolateral papillary muscle. The 3rd branch, which is the largest, is the posterior hemifascicle, and that emerges in the posterior septal region and winds up giving rise to branches that feed primarily the posterior region, running in close approximation with the posterior medial papillary muscle. With these 3 branches, the inside of the left ventricle can depolarize simultaneously, and as I've mentioned in earlier lessons, the electrical vector winds up running downwards and towards the patient's left. But that assumes that all 3 hemifascicles are firing simultaneously, and that the endocardium of the left ventricle is activated nearly at the same time. When one or more of these fascicles is diseased, and by diseased I mean does not conduct as rapidly, there may be conduction delay, then part of the heart may get the signal later than another part, and that disturbs the normal sequence of activation of the left ventricle. Okay, so let's say, for example, and we'll talk about these hemiblocks in detail in the next video, but let's say, for example, there's delay in the anterior hemifascicle such that this blue area gets the signal later than the rest of the heart. So what happens now is the electrical signal travels down the lower part of the heart first because of the septal and posterior hemifascicles activating initially. Posterior medial area of the heart activates first, but then the rest of the heart has to be activated a split second later, and the electrical vector has to turn around by the apex and head back up towards the base. And so what you get is a net shift in the electrical axis. Instead of it heading towards the apex, it winds up turning around and heading back towards the base, giving you a left axis deviation. And that's one of the criteria for diagnosing anterior hemiblock, is a marked left axis deviation. In the next video we'll get into more detail about what a left anterior hemiblock looks like, but it's really marked changes in the axis that allow you to diagnose is disease of the hemifascicles. So for the ECG Academy, this is Dr. Nick. Thanks for watching. Common diagnosis that I see in maybe 2% of the cardiograms that I read. But a lot of the residents that I teach, they seem to forget the criteria, because the criteria is sort of unimpressive, often overlooked. And I find that if you understand why the ECG looks the way it does in left anterior hemiblock, it's much more difficult to forget about it. It's something that you should recognize immediately. And it's actually fairly easy to diagnose, but maybe not so easy to understand. So let's review a little bit, because after all, repetition is the key to learning. So here's our heart cartoon, and you have the AV node here in the atrial septum, and you have the main bundle of His that dives into the central fibrous body and splits into the right bundle branch, which travels down the right ventricular septum in something called the moderator band, and then branches out towards the apex. And the left bundle branch, which is much larger, splits into an almost infinite variation of branching points, but functionally we do recognize three branches: a large posterior hemibundle or hemifascicle, a thinner anterior hemifascicle, and then a septal fascicle, all of which run on the endocardium of the left ventricle. So the septal branch mainly runs down the ventricular septum and winds up depolarizing the septal region. And remember, the septum depolarizes from left to right. And if you think about the chest in cross-section, with this being the spine and this is the sternum, the right ventricle is an anterior structure, and the septum therefore depolarizes mainly in an anterior direction towards V1. And that's all involved in how an ECG looks under normal circumstances. Okay, where the anterior hemifascicle runs across the outflow tract of the left ventricle and terminates near the anterolateral papillary muscle. And so the anterior portion of the left ventricle is fed by branches of the left anterior hemifascicle. Finally, the posterior hemifascicle depolarizes the endocardium in this region here near the posteroseptal region. So what happens when you have anterior hemiblock? Well, remember, block doesn't always mean block. It may be seen in cases where the left anterior hemibundle is simply delayed. So you have delaying of conduction down here so that that part of the heart gets the signal later. Well, if this part of the heart, this green part, gets the signal later, what happens is the septum and the posteroseptal region depolarize first, and then the signal has to somehow turn around and reach this part. Now, the QRS generally should not widen, because the left ventricle is all connected together, and it's not like the signal is getting from the right side to the left side, such as in a left bundle branch block. In left bundle branch block, the signal has to travel very slowly through intramyocardial pathways. But in hemifascicular blocks, the Purkinje fibers are fairly well connected, and so the QRS should not get particularly wide. It should remain less than 120 milliseconds in duration, okay? Just remember that. So in a pure anterior hemiblock, what happens is the electrical signal is traveling kind of in this direction from the septum in the posteroseptal region towards the anterolateral wall in this cross-sectional region. And here in this view, more of an anterior view, the signal reaches the septum and the posterior wall and then sort of has to turn around in order to depolarize the anterior region. In this view, the septum depolarizes, and then what happens is the latter part of the QRS complex is heading in this direction towards the lateral wall. So what happens to your QRS complex? Well, the number one biggest change is that you get this marked shift in axis, this left axis deviation of minus 60 degrees or better. Now, some people say minus 45, but that's sort of splitting hairs. Remember, in your circle of axis, your normal axis is going to be down here in this quadrant, and I generally accept minus 15 as still being normal, but when you get to minus 30, which means that lead 2, which is 60 degrees above the horizontal, is isoelectric. When lead 2 becomes isoelectric, then that gives you an axis of minus 30. How do you get to minus 60? Well, there, when you reach minus 60, AVR, which is 30 degrees above the horizontal and headed in the opposite direction, is perpendicular. So that's the key. The first place you should look is AVR. If AVR is isoelectric or positive, then you know that the axis is going to be in this half of the circle. And so the axis, therefore, is going to be markedly abnormal. So if AVR is isoelectric or positive, then that meets the criteria for hemiblock. And then the question is it anterior or is it posterior? And an anterior hemiblock, being that the axis is markedly leftward, the inferior leads 2, 3, and AVF should be negative, because the signal is going away from the the feet towards the head. They're at about minus 60 or so. But the one thing you need to consider as an alternative explanation for a marked left axis deviation is if there's an absence of signals heading towards the inferior wall. Let's just say, for example, this patient has a dead inferior wall, that they've had an inferior wall MI. What's going to happen is the signals are not going to head towards the feet at all because there's no myocardium to depolarize. And so most of your QRS complex signals, most of your ventricular activation is going to be heading upwards in this direction. And so having an inferior MI gives you a left axis deviation. But as I explained in the next section on ischemia and infarction, if you have an absence of electrical signals going towards a particular location in the heart, then what you'll get on the cardiogram is a Q wave. A Q wave indicates absence of electrical signals in that anatomical region, but that's not what's happening in an anterior hemiblock. There are signals that are coming from that area. And so what you get, instead of a Q wave in the inferior leads, they are negative, but what you get is a little R wave. So the inferior leads exhibit a small R wave, but they're predominantly negative because of the fact that the axis is way up here at minus 60. So when you read the books and they tell you that you should have an RS in lead 3, what is that telling you? It means you have a little R wave indicating that you do not have an inferior infarction, but that you have a big S wave. That's why it's a capital S. The big S wave is simply an indication that the inferior leads are negative because the axis is going towards the head, and that's because you have this left axis deviation of minus 60 degrees or better. Well, the other criteria that people talk about is the fact that there's this QR in lead 1. Well, in lead 1, where does the Q wave come from normally? You should know this by now because we talked about this in several other videos. In lead 1, that little Q wave comes from septal depolarization. So that negative deflection at the beginning of the QRS complex in lead 1 comes from the fact that the septum is depolarizing from left to right because of this purple here, the septal branch of the left bundle branch system. So you get left to right activation here. Well, you want to see that septal Q wave in an anterior hemiblock because you want to know that the septal branch is working and that you don't have an incomplete left bundle branch block where you would normally lose the septal activation. So characteristically there is a small Q wave but a tall R because after all lead 1 is going to be positive because the signal is still heading in this direction. Okay, so you've got this marked left axis, and because of that marked left axis you've got negative QRS complexes in lead 2, but you preserve the R wave there because you don't have an inferior MI, and in lead 1 you expect to see a small Q but a tall R, mainly because we're still heading in this direction. Now if this is very confusing, once I show you an example it should all come together. Here's my first example of left anterior hemiblock, and it looks fairly normal initially. When you look at the forest you can see it's a little irregular. You have some sinus arrhythmia, you have a little bit slower rates here, and then it speeds up a little bit in the middle, and then it kind of slows down a little bit towards the end. So it's just sinus arrhythmia with an average rate of somewhere around 65 or 70 beats per minute. You can see the P waves are upright in 1 and AVF, and so we'll call it a normal sinus rhythm. But when you look for the QRS axis and you look at all these leads, you notice right away that AVR seems isoelectric. Now given that the inferior leads here are negative, and so the QRS axis is heading away from the feet, it tells you that you are at an axis of minus 60 because you are isoelectric to AVR and you are headed away from the feet. So that minus 60, immediately you should think, oh, does this patient have a left anterior hemiblock? Well, to make sure they do or they don't, look for R waves in the inferior leads. Since you see an R wave there, you know this is not an old inferior MI, and you also see a small Q and a tall R in lead 1. Well, there's your diagnosis. This patient has left anterior hemiblock. Some people call it left anterior fascicular block or hemifascicular block if you really like a lot of syllables in your words. And the one thing that I do want to point out is that there's almost always a disturbance in the R wave progression in these hemiblocks. You can see in V1 there's not much of an S wave. Then you have sort of a tall R, almost looks like a transition point in V2, but then it reverses itself, and then you've got basically very small R waves all the way out to V6 with a deep persistent S wave. So the transition in the precordial leads is almost always disturbed, and I generally call it late transition due to the presence of the anterior hemiblock. If we go back to this drawing here, let me just remind you that when you look at the chest in cross section, that what's happening in anterior hemiblock, the signals are heading away from the septum over towards the lateral wall, but the lateral wall is really posterolateral because of the way the heart lies in the chest. So you wind up missing a lot of the vectors that would normally head towards V2, V3, V4. They wind up being shifted posteriorly. And to me, that seems to be the most reasonable explanation to why you get late transition, because of shifting in the sequence of activation of the left ventricle and movement of the vectors away from the anterior precordial leads. Okay, so let's look at one more example, and this is a different patient, but it looks almost the same, and so I hate to talk about pattern recognition, but this is a pattern that you should recognize very quickly after a while. Again, you have a normal sinus rhythm. I'm not going to belabor that point. You've got negative QRS complexes in 2-3 and AVF. You've got a positive QRS in lead AVR now, and you should immediately think of hemiblock when you see a positive QRS complex in AVR, especially with a negative P wave, because if your P waves are headed in the right direction, then you know you don't have something crazy like someone put the leads on the wrong limbs. Well, this being positive and almost as tall